Hello everyone, my name is Matthew Hayes. I'm the president and creator of ScanLab MR and ScanLabCT. Today I wanted to go over one of our new innovations, which is quantitative angiography, and from our perspective, the reason why our existing digital patient had to continue to evolve to make that a possibility. So, for anyone who hasn't seen this before, what we really decided to do about 2 years ago was actually to start creating human simulators. And the idea behind there is to be able to mimic the physiology that exists inside of humans and then put that human simulator inside of our simulator. So we can mimic the environment as well as we can, but if we don't have real humans, there's always going to be some sort of shortcoming when it comes to anything that we were developing. So first thing we did is create a digital human exoskeleton with different body habituses. And we also then started to put the muscles, the organs, bones, nerves, arterial veins, everything inside of this patient. Because especially on the CT side of things, in order to actually be able to do this on a real life patient, what we were trying to do, you would have to give them way more radiation than the actual patient needed. But for our patients, we could be able to do anything we want with them without causing any kind of harm to real humans. So this was step one. The next step, the models that we had acquired and we had created were not meant for what it is that we're doing. This kind of thing has never been done before. And so what we had to do is take those different elements and make them medically accurate. To kind of go along with that, we created a digital environment so we can be able to landmark our patient. We have a digital CT machine. We also have digital injectors, and we can fill those injectors, and we have a digital injector interface as well. And this is where it started getting really fun, to where we now were able to take that digital patient and start to make them look like a CT. So here you see we have a single slice of different parts of the CT, of the patient anatomy. So if I had my line going right through my liver, this is where I start to see my digital version of our liver. This is where I start to see the digital version of our pulmonary artery that you would use, for instance, for a pulmonary embolism CTA study. The next challenge there, because one of these challenges just leads to another challenge, is we wanted to actually start to program the cardiovascular system. So could we be able to go through in the arterial side, for instance, and tell the blood which way we think it should be flowing? And what that allowed us to do is then take our digital contrast and be able to actually watch it move through the human. And we were all very excited about this. This has also never been done before, but we came up with some new problems. At this point, the contrast would just go to the fingers and then come back. And also the beating heart that we were able to give the patient, it beat the same every time. So if you're looking to mimic real human life and real human physiology, this would start to become very predictable. And that's what we don't want, because the thing that makes MRI and CT special is the patients. And each one of those patients, their heart beats differently, they breathe differently. And so the next challenge that we had, let's program this digital heart. So you see, we can program thousands of different variants of the same heart for it to be able to beat differently. I can be able to choose one of these profiles. I can be able to go through to our digital heart and be able to choose a certain view of that digital heart. This is an existing patient profile, but a patient has an age, a respiratory cycle, how long it takes for their lungs to, their diaphragm to rise and fall. But this is where it started to get really fun, is that we could start to program the patient's R to R interval, which is a key component of cardiac and just overall patients in general. You can give patients any kind of cardiomyopathy. I can also make the patient a certain amount of arrhythmic, so they could throw bad beats, we call them. Where it gets even better is now we can be able to start to program how this patient will interact with digital medications. So I can be able to see how that patient will respond to any sort of medication. I can also program to see how many milliliters of blood will enter the systemic circulation per heartbeat, and that's called stroke volume. And in doing that, we can be able to now generate synthetic ECG, and now this patient has taken on a personality of their own. How will they respond to beta blockers? How will they respond to nitroglycerin with beta blockers? How will they respond with adenosine, regadenosin, dobutamine? And so in doing so, now even though the heart it looks the same, it beats very differently, and the contrast would then arrive to different places in totally different times, just like every patient would be different from each other. Remember I said the contrast would just go to the fingers and back. So what we had to start to do is actually program tissue perfusion. And those values exist with ultrasound, with MRI. We know how long typically it takes for contrast to wash in, go across the extracellular, extravascular space, and then re-enter the venous bloodstream. So you can see here, we see the hepatic artery giving way to the portal vein. And in doing so, we could make our simulations of the human vascular system very, very close to real life and very academic in nature. So then we were excited about that. And then we started putting regions of interest inside of certain parts of that patient. And we started having big problems here. This is not what real life looks like. So we just had to make adjustments and adjustments. As contrast washes in to the bloodstream, it becomes brighter, or it has a different amount of concentration due to blood. So we're able to mimic the curves correctly, but you see here, this is a patient with 3 different stroke volumes, 3 different amounts of blood that enter the system for every beat. And that's obviously a mistake here. There's no reason why the second pass of contrast would be so much greater for one than the other. So we had to continue to recalibrate all of our methodologies and all of our sims. Then we were able to do that basically. So this is a patient with 2 separate stroke volumes, and you'll see the patients that are moving blood very, very quickly, we have a higher concentration for a shorter amount of time. Whereas a patient with a lower stroke volume, I don't have as high of a concentration because there's pooling, but it happens over a longer amount of time. That contrast is present within those slices for a longer time. So we knew we were on the right track, so then we just kept getting more and more scientific. So in this case, this is a patient with a single stroke volume, but with different volumes of contrast that we've given for the exact same flow rate. So you can see if this would be a test bolus or a test injection, these would be 10, 20, 30, the contrast duration could be 10, 20, 30 seconds of contrast that's washing in. And obviously if we have a longer or a larger amount of volume, it's going to take longer for that to move into my heart and out into my vasculature. So we knew we were on the right track. Then there was another problem, is that what we had to do then is start to map the way that the human body not only moves when I breathe, but also in the Z direction, started to see how big, deep breaths actually displace, in this case, the liver. So this has been something we've been working on for at least 2 months, because this liver, it's not just that simple. The liver is moving up and down, but it contains the blood vessels as well. So how are we able to track the amount of contrast and dye that is coming through a moving vessel? And all of this has made me realize just how special the human body is just as a whole, and trying to replicate it takes so much work. But there's another part of human anatomy that we hadn't looked at just yet, and that is a beating heart within the lungs. And so to be able to calibrate how the heart moves, how the different coronary arteries move within the respiratory cycle was even more challenging. So happy to say that we've cracked that, and we're able to really fully replicate all physiologic variants within a human responsibly. This really allowed us to take that final leap that was necessary to be able to quantify angiography. And what do I really mean by quantify angiography? So if I'm giving a bolus of contrast, sometimes I'm going to be maybe early. Maybe the contrast has not arrived to the vessel that I want to image, and I don't get very good image contrast. I don't get good opacification of that vessel. Sometimes I'm right on time. That's what we always want to be. Sometimes I could be late, and so there's not enough contrast, or it's washed through and now is in the venous system instead. So what we want to be able to do with quantitative angiography is to be able to tell you how many seconds you were too early, or how you were on time, or how many seconds that you were too late with regards to the timing of your actual image acquisition versus the contrast washing in to those areas of interest. Which led me to think, well, we've created this human and we can do anything we want to this human. So what we did is we created something called, that we refer to anyway, as watchtowers. So these are 51 different locations, sensors inside of our digital human. What we've done here is said, okay, if I'm going to do a chest for a pulmonary embolism, then what watchtowers do I want to turn on? And really this comes down to what areas of anatomy do we want to be filled with contrast when we're actually in the process of taking images. So if I'm doing a PE study and I'm scanning from head to foot, the first thing that we're going to see is the left and right pulmonary arteries, or the branches of the pulmonary artery. And then we'll see the pulmonary root as we go a little bit further. And ultimately we want to see contrast within the right ventricle. And that tells us that we are on time. We're taking those images in a normal amount of time while the contrast is in that area that we care about. I think this is really important that we can actually turn on these different sensors. And really, this is where the digital patient really shines and allows us to go deeper than you can even on real patients. With that said, I wanted to show you how this all fits together inside of ScanLabCT in this instance. So you see, I can see my patient, I can see their height, their weight, I can be able to fill our contrast. And we wanted to do this responsibly, so you'll see there's certain amounts of contrast and saline that are appropriate. We then select one of our digital human family exoskeletons, and we need to decide what position that we want to scan them in. But at this point, the human is, especially for file sizes, the human is empty. But what we're going to do is internally match one of those profiles, those set of parameters, and put them inside of our human. But here we're able to landmark the patient in the A to P and the S to I direction. And something that we've always wanted to do is to be able to really mimic the clinical realness of CT inside of ScanLab. So I'm going to do my test injection. I turned on a breath hold. And something I'm very proud of is always that, you'll see it says taking a breath and hold it. And as the patient is moving in the digital environment, we're actually unveiling the DICOM images as well. So we have full synchronization between the DICOM real images and the digital human. This is an example of a 2D projection. And just like in normal life, I need to go through and I need to find a slice to monitor that contrast. So you see, I've gone too high, so I can see the top of the aortic arch. Instead, I'll go down a little bit further, I'll find my carina, and there I have my pulmonary artery and my left and right branches. And just for this whole thing, I just did a manual bolus timing and just watching. So now I'm just setting up all of my slices, because here, even though these are my areas that are important, I need to scan from all the way inside the chest to look for any kind of thrombi or any kind of clots there. So now you'll see we have our slice that they have selected. And now when we hit start here, watch the digital human start to actually breathe. So now I'm going to start my injection. And this is really important. So in the background, all of my watchtowers that I've told are now turning on. So now you can see this blue line is the one from what the user has placed. But all of these, we need to have contrast inside of these dots so that we can be able to quantify if you're too early, you're on time, or you're too late. So the patient moves in, and now we've done the world's first risk-free, stress-free pulmonary embolism study, but we can actually go further and be able to see, relative to your acquisition time, where were you within the hemodynamic ranges of those areas that we really care about for this study. We're incredibly excited about this. I think it takes us way further than we ever thought we would be able to go with the digital human. And who knows where we will go next, but I hope people enjoy this. I hope people get a lot out of it. And I think we'll be able to give them practice and responsible feedback when it comes to all the different variables that you would have normally in the clinical environment.